Good morning. Today is October the 16th, 2011, and I'm Dr. Alistair Wood, and we're here in Chicago to interview Dr. Margaret Wood, who's the E.M. Papper Professor of Anesthesiology and Chairman of the Department of Anesthesiology at Columbia University. So Margaret, let's start at the beginning and talk about your life growing up as a child.
Well, I was born in Leeds, in Yorkshire, in northern England in 1946, so I was a war baby. It was immediately after World War II had finished. And growing up in northern England, it was a gritty, very northern industrial city with woolen mills and textiles, row-to-row back houses with outside toilets, and there was still rationing until the early 1950s. So it was a very difficult time, I think, but I had a wonderful childhood, had incredibly supportive parents, neither of whom went to university. My grandfather was a guardsman on the railway, but very much knew in education was extremely important. Wonderful conversations, they were very forward-thinking people who questioned ideas and were really social liberals, I think very much ahead of their time. So I look back on it with a great deal of pleasure and very, very proud to be a Yorkshire lass.
Now, had any of your family gone to university before?
No, as I said, my father left school when he was 15, my mother when she was 16. No one in our family had ever gone to university or even thought about it. And it's interesting, actually, the same applied to his siblings, and my cousin went to Cambridge and he became a very famous mathematician. Was elected to the Royal Society and has a Royal Society gold medal. So I think for all of us coming out of that time, we were very much guided towards terrific careers.
What do you think your family felt about you going into medicine? Did they encourage that, or were they concerned about you going into medicine?
No, they're very proud, they were very excited. My father used to bring a book home every Friday night for me. He knew I loved reading. I used to walk to the library and loved books, and he used to bring a book home every Friday night, and I used to devour it and had always finished it by Monday morning. And when I was 11, he brought home a book called The Citadel by A.J. Cronin. And I think that book was instrumental in my becoming a physician, being a doctor. It tells a story of a man called Andrew Manson, who went to St Andrews. He went to a Scottish university, and then went to the mines, the coal mines in Wales, to be a colliery doctor, but always applied the scientific method, a scholarly approach to how he treated his patients. He did lose his moral compass, his pathway during the book, which is what makes it such a tremendous book. I think it lives for today as well. But having read that book, I decided that I wanted to be a doctor as 11, and I wanted to go to St Andrews University in Scotland, and I did.
And you did. You went to St Andrews.
Yeah.
So take us through in what it was like to leave and go to university at that time, and sort of think about how that compares to our own children and their departure for university.
Well, my father went out and he bought a big trunk, and I put all my possessions and books and clothes into the trunk, went to the Leeds City Station, and trunk was loaded into the guard's van at the back, and got on the train. My father said goodbye, and off I went to university. And in those days you went a long way, and I didn't see him until the Christmas holidays, and went off on what was an incredible adventure, I think, for an 18-year-old to go to university, to medical school. Compare it to my children, who both went to Columbia College. we moved them in, both of us, and took their possessions to their rooms and spent a lot of time with them that day.
My recollection
very,
is most
different.
of the carrying was done by me, but that's...
That's probably true.
So there you were as an 18-year-old girl, young woman, arriving at medical school, and of course in the UK you went straight into medical school from high school, I guess.
Yes.
And you started right away in an anatomy dissection class. How did medical school, do you think, differ in these days from now in 2011, particularly for women?
Well, 10% of the class were women, which is very different from today when more than 50% of a medical school class are women. I very much enjoyed it. I think there are difficulties in being a woman in the medical profession, going through those times in the 70s, but as a medical student, had a wonderful time. Very much I felt part of the class, although we were aware to some extent that we were different. The thing that I remember the most from my first week at medical school was the chairman of anatomy, Professor Rex Copeland, who gave us a lecture as to how you can have three things in life. You can have a career, you can have a job, that's one. You can have your own hobbies and interests and things that you like to do, that's the second part. And then the third thing is you can have a family, but you can't have three at the same time. You can have two at the same time, and you can have three throughout your life, but you can't be successful, and you certainly will not finish medical school if you try and have three at the same time. And I thought, oh my golly, this is going to be so hard. I'm going to work really, really hard. Certainly want to pass the first year exams in medical school and not be, as they called it in those days, thrown out. But I think in actual fact it was very good advice, and it's advice that I've carried throughout my life, my professional life.
Now this was I guess the mid-60s.
Right.
So what was life like in the mid-60s for people who did not survive that time?
Well, because I was born in 1946, there was clearly a group of very well qualified young people marching through that period. It was a time of the Beatles, it was a time of the pill, it was a time of miniskirts, short skirts. So the poverty and the difficulties that I talked about in the 50s had certainly gone, and Britain was on the move, and it was a very exciting time, and we thought we could do everything.
Right.
Very
right.
optimistic,
Yeah.
positive time to be in medical school.
Right. What do you remember about your first days in medical school?
Well, there was one momentous occasion in anatomy class. I met my future husband there, sitting opposite me now. I always say I met Alistair over a dead body, over a cadaver, in anatomy class, and we became great friends. Did not know I was going to marry him in the first year in medical school, but we went to classes together, we compared notes, and Alistair's always been my best friend.
Now, obviously this was a formative part of your life, particularly as it led on to the rest of your career. What were the things in medical school you think that influenced your choice of and what you did after medical school?
In Scotland, the pharmacology department was called the Department of Pharmacology and Therapeutics, and I think the way that pharmacology was taught in Scotland in those days, which was how to prescribe rationalization of drug therapy, not just the structure of the drug and its effects, I think had a great influence on my life. The chairman of pharmacology, latterly Professor Crooks, was a clinical pharmacologist, so I found pharmacology extremely interesting and did very well in it, very much enjoyed it.
And then what about other basic science like physiology and even clinical subjects like pediatrics?
Enjoyed physiology. Really enjoyed pediatrics. It was something that, as part of hospital medicine, perhaps not out in family practice, but as part of acute hospital medicine, congenital heart disease, rheumatic fever, pediatric cardiac disease had immense appeal to me in those days.
And of course you did very well in pharmacology and physiology and pediatrics at medical school, as I recall. Now, when you graduated from medical school, you obviously made a choice to go into anesthesiology. What were the things that influenced your choice of anesthesiology as a specialty over the other things that interested you? In fact, perhaps I should ask you first, what other things did you consider before you chose anesthesiology, or did you?
I considered forensic medicine because I thought that was fascinating, but I was well aware that in the United Kingdom there are not many murders, and there's usually just one Home Office pathologist. So I did not see that as something that had a long-term future, but I did find it very fascinating. I knew I wanted to be in academic medicine. I loved the teaching hospital, the acute care medicine, being at the cutting edge of exciting activity. Very much enjoyed the professors and the people who had taught me. I knew I did not want to leave that environment, and for me, I knew that family practice, general practice, was not the right environment. And I believe that as a woman wanting desiring an academic career, anesthesiology was a new specialty. It was very much underrepresented, and I saw a future in anesthesiology. Intensive care units were just starting in those days. The first coronary care units were being set up. So I thought for me it was also a way of doing pediatric anesthesia as well, and again a new specialist practice. I thought that would be the right thing for me, and decided to do anesthesia. Was not exposed to it in medical school. It was not something that was taught, but I knew immediately I started that I loved it and that I had made the right choice.
Now, during your residency, you went to Liverpool for a bit. Tell us about that experience.
I did. I went to Alder Hey Hospital, which was a postgraduate pediatric hospital, only to work for a very short period of time, 6 weeks, but to work with Jackson Rees to really learn how to anesthetize neonates and very small infants. And working with Jackson Rees, the Liverpool method of anesthesia with hyperventilation, narcotics, no inhalational anesthetics were administered, for me was a groundbreaking experience, and I think gave me confidence later on in pediatric anesthesia that after all I trained with Jackson Rees and learnt a lot from him, and it gave me confidence, I think, to do neonatal anesthesia later on in life.
Now, particularly as this is a history a video, can you tell us anything about Jackson Rees and give us some sense of what he was like as a person?
He was a wonderful person. He did have a very small chin, and he always said that he would be a difficult intubation if he required anesthesia. He had micronaphia. And he smoked. He smoked a lot. And he used to always, when we were doing cardiac cases, he would go outside to have a cigarette when the patient was put on cardiopulmonary bypass, and he would be called back in a rush when we came off bypass, and he'd come rushing in, and you could see a cigarette in his pocket and the smoke coming out of his pocket in his scrubs, and had a twinkle in his eye. Everyone knew what he had been doing.
I suppose in these days you didn't have to go outside the building to smoke either.
Absolutely, yeah.
Now, did you do research when you were a resident?
I did do research as I was a resident, and continuing my interest in pharmacology. I worked with Ian Stevenson, who was a biochemist. The biochemistry department in Dundee in Scotland was extremely well known, run by Jeff Dutton, who discovered glucuronidation. Ian Stevenson was recruited to the pharmacology department there, a wonderful raconteur in the pub, I should say, and he encouraged me to do research even as a resident. And I looked at antipyrine half-lives, which were used as an index of drug metabolizing ability. I measured them in operating room personnel, my colleagues, the nurses, the operating room technicians, residents, and so on. Everyone who worked in the operating room were my human subjects. This was human research. And I did it in my post-call days. There weren't any hours rules then. Went on to show that indeed operating pollution, exposure to halothane, did indeed cause enzyme induction in people working in an operating room exposed to inhalation anesthetics. And this was before scavenging, and to some extent my work in part did change OSHA rules and so on for scavenging and pollution in operating rooms. But I think the big thing was working with Ian Stevenson and then presenting my work at the Anesthetic Research Society, which was the equivalent of the Association of University Anesthesiologists in the US, the AUA, being sent to Edinburgh very early on to present there in my first year of residency, and talking to people, meeting all these people who came up to talk about my work, seeing what science was really like, I think was pivotal for me. And the idea of having young people do research early and go out and present early is something that I've carried through with me throughout my life. And when I started the APGAR Scholars Program at Columbia, that was something that I decided to institute. It was part of the APGAR Scholars Program that young residents should go to meetings and should present early and get a taste and enthusiasm for the outside world and science.
Well, we'll come back to the APGAR Fellows Scholars again. I guess one thing about the Anesthetic Research Society was to become a member you had to present a paper, and so because there was a limited number of papers presented, only a relatively small number of people became members. That was an odd, perhaps peculiarly hierarchical system, I guess. That doesn't apply, I don't think, to learned societies in this country much.
No, it does not.
Right. Yeah. Maybe it's a good thing.
Yeah.
So you did research during your residency in Scotland, and then in 1976 you came to the United States, to Vanderbilt University in Nashville, Tennessee. How did that happen? How did you end up moving from Scotland to Nashville?
Before I came to the United States, I'm not sure I'd even heard of Nashville apart from having seen the movie. My husband, Alistair Wood, who's here in this room today, won a Merck Sharp and Dome traveling fellowship, scholarship, to study anywhere in the world that he wanted for 2 years in clinical pharmacology. And we chose, at least Alistair chose, and I was very happy to go along with him, he chose Vanderbilt, which had an excellent clinical pharmacology department, an excellent pharmacology department, and Alistair came for 2 years to Vanderbilt, and I was fortunate enough to be recruited by Bradley Smith to the Department of Anesthesiology there, and did a cardiothoracic anesthesia fellowship there.
So you got to Vanderbilt. Tell us about these Vanderbilt years.
Well, I think the first thing is that you alluded to the fact that the United States, that academic medicine was much more open, and I think that was very true. That appealed to me very much when I first arrived here. There was an openness, there was an enthusiasm, there was a can-do approach, a doability approach to things. It was a very exciting time. Brad was very, very supportive of my doing cardiac anesthesia. He supported my research immensely, encouraged the collaboration of my research with the Department of Pharmacology, of which my husband was a member, and mentored me, did exactly the same thing that had been done to me in Dundee, encouraged me to present at the AUA, and moreover gave me financial resources, and it was a constancy of commitment to always having a laboratory technician. I did have grant funding from NIH and also from the American Heart, but the idea of having constant support I think is very, very valuable, and certainly allowed me to develop a program that I never would have been able to do without that kind of departmental and chairman's support.
So what were your interests in research? What did you actually pursue?
I was interested, continuing my past interest in pharmacology. I was interested in anesthetic pharmacology, cardiac physiology, drug metabolism, and it spanned early work in variability in anesthetic drug disposition and metabolism, moving on later on to molecular biology and the genetic control of drug metabolism.
And clinically at that time, this was this was the middle 70s, I guess, 76 and onwards. You did almost entirely cardiac surgery, neonatal cardiac surgery, you've told me. Tell us about that. What was happening in neonatal cardiac surgery at that time?
Pediatric cardiac anesthesia and pediatric cardiac surgery was a specialty, I think, that was really coming into its own at Vanderbilt. Pediatric cardiologist Tom Graham, pediatric cardiac surgeon Harvey Pender had been recruited a few years beforehand, and we started doing hypothermia and circulatory arrest in very young children, and this was very, very exciting. I had done hypothermia surface cooling for aneurysms actually in Scotland, in Dundee, for cerebral aneurysms for adult patients, but had certainly not done hypothermia circulatory arrest. And I think I did the anesthesia along with attendings. I was a fellow at the time with the anesthesia attendings there, Boyd, May and Brad. The first case that we did at Vanderbilt, and I said, I didn't know that, and I said at the end of the case, well, that was the first one I'd done, and Harvey turned around to me and the anesthesiologist and said, us too. So it was very exciting, and it was a chance to really leap forward. It was a thrilling time.
Now, you had a joint appointment in anesthesiology and pharmacology, or at least later in your period at Vanderbilt. Do you think that influenced you in the future, or do you think that's an important thing for people to do today?
I think the chance to collaborate with others is paramount for anesthesiologists. But I think it's important to recognise it's very important to be in a great department and have great mentors. And I think when I was in Scotland, I didn't realise how famous and how well known and how great my mentors and collaborators were. That applied there, and it also applied in Nashville in the Department of Pharmacology there. That I was working with a stimulating, innovative, enthusiastic group, Dave Shand, Grant Wilkinson, Alistair Wood too, I have to say, working with a very, very great group, and we were at the forefront of clinical pharmacology at that time. The other thing that I think was very important was that the 80s were a time in anesthesiology of immense growth in drug development. And that was, I think, very opportune for me in terms of anesthetic intravenous induction agents, propofol, benzodiazepines, midazolam, opioids, new muscle relaxants. And not just anesthetic drugs, beta adrenergic blocking agents, calcium antagonists. There really was an explosion in drug development in anesthesia during that time, and that allowed me to use new drugs, to do research in drug development, which I think was very fortuitous at that time.
And of course, together we wrote a textbook of pharmacology for anesthesiologists.
We did. We wrote a textbook of pharmacology, drugs and anesthesia, pharmacology for anesthesiologists. And I have to say, I can't remember a single argument. I'm not sure what you would say. But it was very nice to have someone that you could say, I don't know, and it didn't matter. And we could discuss things and realize that often things weren't known. I very much enjoyed doing 2 editions of the book. It was published all over the world. I started the book actually using my notes for my board certification. Those were actually the beginning basis of the textbook. Very pleased about the dedication at the.
Tell us about the dedication in the front of the 2nd edition.
The dedication read to Alistair and Ian, without whose help this book would have been finished in half the time.
And of course, Alistair and Ian are your 2 sons, who we'll come back to talking about later.
That is correct.
So while you were at Vanderbilt, you did clinical work, you did research in pharmacology, and you wrote a book. But I guess the other thing you did was you had 2 children. That's often seen as a difficult thing for professional women to pull off, and to continue to maintain their career. What are your thoughts on that? How did that work out, and was it difficult?
It didn't feel difficult at the time. It felt fantastic. I did take Professor Coupland's advice and concentrated on my family and on my career. But my 2 boys were absolutely wonderful, and there was never a time, I think, when any member of my family was upset that I wasn't there or said, please don't go, we want you to stay. They were tremendously supportive. Both my boys were tremendously supportive of, and I hope and I think very proud of what I did, not just the research, but the fact that I was a physician and in their view was saving people's lives and giving young children with cardiac defects at least participating in their futures. They were very proud of that and were wonderfully supportive of me.
And if I'm permitted to editorialize, you were certainly a wonderful mother, and they clearly understood who their mother was. No question of that. So that's taken us sort of into the 80s. How did anesthesia change in the 80s, and how did that lead into where we are today, do you think?
I think the improvement, I think the explosion of new drugs in the 1980s allowed anesthesiologists to recognize that no longer was it, and also the changes in patient safety, the Anesthesia Patient Safety Foundation, no longer did it become a success that a patient woke up safely from anesthesia. That was an expectation. It was how they woke up and were they able to read a newspaper in the recovery room and so on. And I think those changes allowed anesthesiologists to concentrate on the whole of the perioperative period, to look at more long-term outcomes from anesthesia and surgery, and to concentrate on the preoperative part of the procedures and also the intensive care units, and take a more long-term view to anesthesia.
Then in 1996 you were recruited to Columbia as chairman. Tell us about that and what that transition was like.
Well, I had at Vanderbilt become a full professor, I was the division director for cardiac anesthesia, and round about that time, perhaps a few years beforehand, started to get requests to interview for chairmanships. And in 1996 I was asked to assume the chair of anesthesiology at Columbia. It was a tremendous honour. It was a department that was a very good department. I hope in the 16 years I've been there that I've made it a better department, but it was a very good department at that time. And it was a department with a very proud history. Virginia Apgar was there, and Manny Papo was the founding chair. Ed Miller was my preceding chair, who went on to Hopkins and became dean and president at Hopkins Medical School. It was a position that I was very proud that I was offered the position, and I decided to take it, to accept the position.
Now, before Ed, for those who don't know, Ed is an extraordinarily tall guy. You're extraordinarily small, 4'11", I think. And tell us about Ed's furnishing tastes when you arrived there.
Well, I'm sure if anyone saw us together, they would realise how tall Ed is, and I'm very small. I did use his office, obviously. It was a lovely office. There's only one thing that I had to change, and that was a chair. I did need a new, smaller chair that my feet could touch the ground, but yes, yeah.
So you arrived at Columbia in 1996. Tell us what the environment for anesthesiology was like in 1996 and how it was to arrive at that time.
I went to New York in July 1996, and the March match had demonstrated quite clearly that, I think because of the ideas about healthcare reform, that perhaps specialists and anesthesiologists in particular might not be an area where we would need many anesthesiologists. And the match in 1996, I think there'd been something like 67 US seniors who had matched for PGY1 positions. Columbia got one of them, but there was a recognition that very few people, or a reduced number of people, were going into the specialty, and that would mean a few years down the line that there would be a shortage not only of residents but also of anesthesiology faculty. Perhaps academic faculty would go into private practice, but it certainly was a crisis, I think, for the specialty. So it was not the easiest of times to assume a new position.
So you arrived there and you had, how many residents had you actually matched with?
In the first year class, there were 3 residents.
Right. And just
in
sort
July.
of to jump forward, how many residents?
We now have 26 residents per class, 104 residents, 27 fellows, and of course research fellows as well.
Right. So you arrived there. Share with us what your vision was for the department and what you wanted to achieve with the department at that time.
I think the fact that the specialty was in a crisis was actually, although it wasn't easy, was perhaps not a bad thing, because it allowed me and my department to come together to realise that if we were going to survive and be an academic department, a top-tier department in the top 10, then we would have to look at what we were doing and really, really be the best to attract first-class residents. So we looked at everything we did and changed a lot of things and concentrated on our education, our teaching, our research, renewed our T32 training grant. So by the time the upturn came, which indeed it did and which we indeed thought it would do, I think we were well positioned to recruit first-class residents, and that we did. The other thing I wanted to do was I wanted to start a mentoring program, and I wanted to start a program that was similar to the way that I had been mentored in Dundee, where I'd really been well taken care of, and where at Vanderbilt, as a faculty person, I'd been well looked after. And I started the Apgar Scholars Program in 2002. The idea being that medical students would come into the department knowing at the very beginning, committing to doing 2 years of research, clinical fellowship training as well. So it would be a 6-year continuum, and we would ask them to join the faculty afterwards, and the mentoring would continue. They would be named APGAR scholars, and I think it's been very successful thus far. We encourage them to present on the national scene very early, and I think perhaps that the true fruits of the programme will be more evident when I'm not chairman, as time evolves. For me, what's been very gratifying is to find that other departments now, I think 10, 15 departments, now have similar programs, and so I think for the specialty as a whole, it's going to be, I hope, something that will improve the research base. Not improve the research base, that's not the right word, grow the research base. I think anesthesia research was always very good, but needs to be larger. It will grow our research base. Because if I think we're not committed to research as a specialty, and we don't recognize that we have to do research to improve our specialty, to improve our clinical care, then I think that we will not survive as a specialty.
Well, creating the APGAR Fellows Programme is clearly one of the most visionary things you've done. Give us a sense of how that's worked out. First of all, when do you recruit them? They come into the programme straight out of medical school and are designated as APGAR Fellows? Is that the way it works? Or?
They are. The concept or the notion being that by the time they're a third-year resident or even a second-year resident, identifying a mentor, deciding on what they want to do, getting an animal care protocol or an IRB protocol organised is perhaps too late. So the first 18 months they're looking around the institution, getting a feel for what they like, what they enjoy. We don't ask them to make a commitment there, but they do come regularly to the APGAR dinners. We have an APGAR day, and they see how the older APGAR scholars are doing and what's happening to them. They get to know the APGAR scholars, who interestingly enough in their own right are mentors to the younger APGAR scholars. That was something I didn't expect to see happen, but which has been a very nice thing to occur. And then later on, second year they identify a mentor. The third year they're getting organised in the lab so that when they do their fellowship they can hit the ground running, and they do.
Right. So you wanted to strengthen academics in the department as part of the vision. How do you maintain the multiple parts of a department successfully? Because there's no question anesthesiology has a major clinical commitment in every hospital, and maintaining all the parts of the department and keeping all of them running must be tough. Tell us about that.
Well, I think it's important to have a culture of interest, of inquiry, and I think it feeds upon itself. So the individuals who do research as they stay in the department then become the mentoring culture for the younger people, and that culture of being in the operating room and doing research I think means that the attendings who do not do research but have known these individuals as residents have great affection for them. They knew them when they were doing their residency, and therefore I think have been very supportive of them. That said, I think 2011, 2012, although we do have some triple threats who can do everything, that's a rare person, and I think our goal as a department is that the department is a triple threat, and working together, all of us together doing different parts of the program, we can come together and be a triple threat. But the idea that everybody can do it, everything, I doesn't think exists today.
So that's an interesting concept. So what you're saying is that the department as a whole provides excellence in clinical care and academics and teaching, but each individual contributes differently to that. Is that or can contribute?
That is correct, and I've always worked very hard, and the departments work very hard at finding a niche for everyone, whether it's in population science or patient safety. The patient safety person could work with the population science researchers, whether it's practice management, OR management, pharmacy and therapeutics committees, and so on. That there is a niche for everyone, and everyone has a special role, and that was a reason to be in academic medicine. Education, tremendously important.
Now academic departments of anesthesiology, I guess, traditionally have had basic scientists in the department and clinical scientists in the department doing research. One of the things I know you did that always struck me as pretty innovative was to reach out to population scientists and recruit population scientists, epidemiologists, into the department. Tell us what took you to that and what made you decide to do that.
There were a number of reasons. I think that I was very fortunate in going to Columbia and there being an excellent School of Public Health, and Alan Rosenfeld, who was initially an obstetrician, was the dean there. He actually came to all the chairman's meetings, so I got to know him very well, and that's an unusual thing, I think, for a dean of public health to do, and he interacted during those meetings, so I got to know him well. I realized that human clinical trials were becoming more difficult to do. They were becoming multi-center trials that were, to a large extent, run by large professional organizations, and that's something that we could do and do very well in anesthesiology was actually population science. And some of the things that we were doing there with genetics, for example, could be linked to population science. And then the other thing that really made up my mind to do it was I had a Finster chair, Mike Finster, who was a wonderful obstetric anesthesiologist, I should say, absolutely famous in his own right at Columbia for many, many years, made Columbia famous for obstetric anesthesia, carrying on in Virginia Apgar's footsteps. He retired, and we were able to raise money for a Finster fellowship. But I couldn't get space for the, if it were going to be a basic scientist, at least large enough space for an endowed chair. Space is very difficult to come by in New York. Manhattan is an island, and there wasn't going to be any more building for some time. And I realized that population science required much smaller dry space, if you will. So putting all of this together, I was able to recruit an absolutely fabulous individual from Hopkins, from the School of Public Health there, that filled that position at Columbia, and he's been enormously successful. And many of our young residents are very much attracted to work with him, and it's been an immense pleasure to see that area blossom and bloom at Columbia.
And I guess as one measure of success, this last year you were ranked number 4, I think, in NIH funding nationally. Is that right?
That's true.
Right,
yeah.
right. And that's and that made you the second highest ranked department at Columbia, actually.
True.
Right,
yeah.
Right. So that obviously there's been substantial progress in academics and research in the department over the 16 years. So, you know, right at the beginning of this, when we were talking about you going to medical school, you talked about there being, I think, 10 women in the class of 100 and something. So there was obviously relatively few women in the class, and relatively few women who became teaching hospital residents, and relatively few women who, certainly few women who went on to academic medicine. So that gave you the opportunity to be the first woman president of the AUA and the first woman chair at Columbia and the first in lots of things. But for women today, there's not going to be that same opportunity because more than 50% of the classes are now women. Do you think that's going to have a positive or a negative effect on them, or how do you think it'll be? Because obviously you've had a lot of opportunity to be the first at things that the women of today won't have, which seems to me a little sad almost. Maybe that's silly.
There will always be mountains to climb. There will be always challenges, important things to achieve. That will always be there. I think that I was extremely fortunate, had wonderful mentors, and my mentors were by their very nature men, and full tribute to all of them. That was a very important thing for me, and perhaps having women as role models. My first endowed chair, the Ben Dixon chair, was taken by Carol Hirschman. I think that in itself, having a female woman holding an endowed chair there, was an important advance and an important role model. I think the thing that is a problem for women that remains today is mobility. When I was giving anesthesia, I think in the early days, I think it was quite soon recognized that women were extremely competent, that they could give as good an anesthetic as a man could, and were very good, achieved board certification and so on. So I think their competence was never in doubt. I think as time went on, the question was, but could they be administrators? Could they manage the money? And clearly they could. They managed their grants. They managed departments. But I think the next step, as to whether they're chairmen of departments, whether they're deans, the next step, I think, in leadership is mobility. And that is a very difficult thing, I think, for families today to come to terms with, and perhaps more importantly, for women. I think
explain what you mean by mobility.
To move to the next job. I think that for men, I think it's sometimes assumed that the man will move for the job, but they don't ask the woman if she's interested in moving because they assume she won't. And in actual fact, if you take my case, when I moved to Columbia, the interviewer here, you, my husband, did not move. You stayed on at Vanderbilt for another 10 years. You were Assistant Vice Chancellor for Research. You too moved Vanderbilt up the rankings, up the NIH rankings and US News and World Report. But you did a tremendous thing for me. You commuted to New York on a Friday and you commuted back to Nashville on a Monday morning. And I don't think many husbands would have done that. And that was something that allowed me to take on the position of chair at Columbia. And so I think mobility for couples will remain a problem, and I'm not sure I know the solution.
Right, but I suppose in the traditional, the older time perhaps, when the man worked and the woman didn't, the woman moved for the man's job, and that's going to be difficult to square in the future. Do you think people will be less mobile in the future, or do you think we'll have to be more adaptive to two-career couples moving?
I think you've seen other two-career couples, Ed Holmes. There are starting to be quite a few two-career couples now. Janine Weiner-Kronish moved to Mass General recently to take the chairmanship there. I think it may be something that's done more often.
So Margaret, traditionally, the people saw anesthesia as somebody who put a patient to sleep and woke them up, preferably the latter. My sense is that you've always had a broader vision of what anesthesiologists should do than that, and that's played out in how you've developed your own department. So can you tell us and share a little bit about that?
Yes, I'm always struck by the fact that I think anesthesiologists, when they're in medical school, always like everything. They have wide-ranging interests and views, and that's certainly the case for me as well. And I really believe that for anesthesiology to survive as a specialty, it's important that we recognize that nothing's off limits, that our interests can range from critical care, from pain, palliative medicine, injury. One of the themes of my department is injury, whether it's kidney, heart, brain, critical care. Nothing's off limits, and our research can be in wherever it takes us, wherever the questions take us, we go to the next step. And I think that's an important vision to have.
Now, one thing that I've heard you talk about before, so I know you know what you think about this, is the idea that some people have that anesthesiologists should only do research within their own department. My sense is that's not your vision, actually, and you yourself obviously did research in an excellent pharmacology department at the time, the best pharmacology department in the country. How do you sort of operationalize that for your own fellows and faculty now? Do you still believe that? And if so, how do you make sure that they get the benefits of the experiences you had?
We place our fellows right across the spectrum, all across Columbia. We have someone in the diabetes center, we have someone in physiology, we have someone in neuropathic pain and neurology and physiology. So we think people should be wherever the right fit is, the right mentor for their interests.
So when you're trying to place somebody, or when you're sitting talking to a fellow or a resident or somebody who's expressed an interest in following a research-based career in anesthesia, what are the things you look for in a department or a lab that you'd want to place them in?
When I'm talking to the residents or the fellow, I think it's very important not to let them do exactly what they want. I think it's important to recognize that if Columbia does not have the level of expertise for what they would like to do, I tell them, well, you need to go somewhere else to do it. But what we have is A, B, C, and D. That's what Columbia is good at. You have to work in a really good lab with a really good mentor. So when I'm trying to place someone, when I'm looking for someone who they could work with, and it could be in our department. We have many wonderful people in our department that they could work with as well, who they could work with. It's the quality. It has to be the best. I had that in Dundee. I had that at Vanderbilt, and I do recognize that if they're going to be successful, they have to go to the best lab. And so that's very important. That's something I look for in the lab. I also look for someone who's going to mentor them, who's going to be unselfish, and is going to recognize that it's a job, looking after someone and guiding someone like that.
Right. In trying to think through which is the best lab to go to, I've heard you say this before, but you clearly put a lot of thought into both the productivity of the lab and the fact that the lab is using cutting-edge technology. That's something that residents and fellows sometimes feel uncomfortable about. They're most comfortable doing things they've done already, rather than challenging themselves to do something totally different or totally new. How do you deal with that?
I think that's true, and that's why I think it's important that they go to a well-recognized mentor, someone that they have respect for and the world respects, which gives them confidence.
Right.
I think that's very important.
And uses cutting-edge technology.
And uses cutting-edge tools. That was something that happened at Vanderbilt, and was what made, for me, Vanderbilt very exciting, was the fact that at that time, science was developing quantitative measures. Measurement was starting with GC, HPLC, mass spec, and we were able to measure metabolites, measure drug concentrations in very small amounts of fluid. And I talked about hypothermia and circulatory arrest, the ability to measure plasma catecholamine concentrations in tiny amount of blood from a very small baby during hypothermia may not seem an advance in 2012, but at the time was. And that was an example of going to a lab with cutting-edge technology. And that's very important.
Right, and I guess you worked with people like Ian Blair and who used HPLC mass spec and so on to measure plasma concentrations.
Right. Exactly.
Right. So in terms of broadening the clinical base of anesthesiology, enumerate for us the various subspecialties that might be viewed as non-traditional that exist at Columbia, things like intensive care, palliative care, and how you got into that, and why you think, for example, palliative care is relevant to anesthesiology.
One of the things that I determined to do at Columbia was I wanted to make the Department of Anesthesiology, and I haven't done it yet, but I think I'm on my way. I wanted to make it a large department because I believe that there is value in being big. You're able to do more, and I wanted to create subspecialist divisions that, although not departments in their own right, were, compared to many anesthesia departments, big divisions, perhaps 15, 20 faculty in these divisions. And I think subspecialization is a very important part of the future and the progress for anesthesiology. And I wanted to link them with parts of other subspecialties that I thought were going to be very important in the future for future hospital care. We have really expanded critical care and really do a major part of critical care at Columbia now. We run 3 large intensive care units. It's become an enormous part of our department and a huge division. Pain medicine research, the biology of pain, linking up with other neuroscience researchers at Columbia, has become a very large division, taking everybody into account, not just our department. And I think palliative care medicine, although it's relatively small at the present time, I think that's going to be in the future a huge part of hospital medicine, and I think it's going to have a huge link to critical care medicine. And if we're going to keep our role and our presence in critical care, I think palliative medicine will become an important part of what we do. And if we look at our population science work, which at the present time is devoted to a large extent to morbidity, to mortality, to injury, to risk assessment, developing indices of risk, critical care outcomes, I think another part of that naturally will lead on to using these outcomes to look at palliative medicine. And I think that's going to become in the future an enormous national push, problem, controversy, something that we're all going to have to deal with in the future. And I wanted our department to be a part of that. I think there are only 2 departments of anesthesiology in the country that have palliative medicine housed in their department. I think Dartmouth and our department. And I think that's going to be immensely important. And I think it may change pain medicine. The way pain medicine and the relationship with the pain medicine fellows and the palliative medicine fellows, I think, has enormous potential in the future. So yes, I do see anesthesiology moving outside the operating room even more. We've already moved to proceduralist areas, to cardiology, cardiac cath, GI endo, many procedural suites, especially in pediatrics. But I think our specialty should move more outside the operating room, and indeed is doing that.
One of the visionary things, I think, that you did that I must say caught me a bit by surprise as an internist was the idea of recruiting palliative care physicians into the Department of Anesthesiology. And the thing that I think was visionary about it was that many of us, myself included, had thought of palliative care as being an end-of-life specialty that was largely focused on cancer and other patients for whom there was no ongoing treatment. The thing that was distinct about your vision, though, I think, was that you recognised that we'd never dealt with the same problems with patients who entered an intensive care unit and then remained there for prolonged periods of time, still having invasive procedures done, receiving care with relatively little analysis of what the outcome for them as an individual would be, and discussions with their family about whether this was still the most appropriate form of care. That seemed to me a nuance that was totally new. Is that fair?
I think that it is fair, and I was struck by it very much in the critical care arena, and I think it's a new area for palliative medicine. Saw it with, we have an enormous transplant program at Columbia, cardiac, liver, kidney, and so on, and a lot of patients using ventricular assist devices. So palliative medicine is not just cancer treatment, it's many other things. It's breathlessness, for example. I think the other area where palliative medicine could be of immense importance is in the emergency department, where I think the recognition of palliative medicine as patients arrive there can be very important, and we see them should they come to the ICU and so on, and what should happen, and what should be the right treatment.
Sorry. Would it be fair to summarise something like this, that when you started as an anesthesiologist, anesthesiologists were this was in the 70s, I guess. Anesthesiologists really confined their attention to the operating room. But as academic medical centres have changed dramatically to become much more intensive in the acuity of care and the kind of patients they're taking care of, that anesthesiology has expanded really across the continuum from the operating room to the intensive care unit to the end-of-life care to really the full continuum of care. And of course relieving suffering and pain throughout that continuum. Is that a vision that you think is sustainable going forward?
I think it has to be, and no one knows what's going to happen with healthcare reform. This is 2011, it's a historical interview, I recognise. Whatever happens, that has to happen, and perhaps anesthesiologists can be the prime mover in, we've seen the medical home, perhaps anesthesiologists can be a prime mover, a driver in the surgical home, or perhaps better named the perioperative home.
One of the other things as an internist that I've noticed is that as internal medicine has become more specialised, more and more internal medicine specialists are less and less competent in broad areas. Gastroenterologists pass catheters and scopes and are really not comfortable doing much general medicine. They're certainly not comfortable with some of the more intensive stuff, many of them. Similarly with cardiologists and others. Is it that anesthesiologists are taking over that care? Because that certainly seems to be the case. Surgical post-operative care is done often largely, if not exclusively now, by anesthesiologists. Are we going to see more and more that others, interventionists, take care of the intervention, and then we're going to be looking for people to fill that void afterwards who may well be the anesthesiologist? Is that the way you see it going, or what do you see happening?
30% of our adult surgical cases at Columbia and almost 40% of our pediatric cases at Columbia are performed outside the operating room area. For the adult cases, many of these cases are medicine procedural cases, notably GI and cardiology, where even now doing minimally invasive valve replacements, vascular cases outside the operating room. And I think that we're now working with specialist internists. We have a long history of working with surgeons over 50, 70 years, I don't know how long. And we've come to terms with how we prepare patients and how patients are looked after. It's really quite interesting when we look at this group of patients, how anesthesiologists are indeed, even though internists are doing the procedures, looking after them. It was not something that I expected, but we are indeed providing the perioperative medicine part of their experience, which is quite an interesting development. So I would say that you're absolutely correct, that anesthesiologists are providing a large part of the perioperative care, perioperative medicine for this group of patients, whether they're surgical patients or whether they're procedural, they're undergoing procedures, and their attending of record is actually an internist.
Right, and I guess we saw that in the past when radiologists started doing procedures and were not able to, or didn't feel comfortable taking care of patients post procedures, and somebody had to step in to fill that void.
We did that as well, yes.
Right. So you've told us that neither of your parents went to university, and I know they were, I'm sure, immensely proud of you becoming a physician. Neither of your parents actually lived long enough to see you really become successful. Tell us how that affected your life.
My father died when he was 50 in February 1970, about 4 months before I graduated from medical school. So he didn't actually see me graduate from medical school, but he was very, very proud of me. And my mother said when we had lunch together before the graduation ceremony that he would have been very proud. I remember when he died, I went home to the funeral and came back, and you picked me up from the station. And so I was very lucky that I've only had 2 men in my life, but they've been absolutely fantastic. And my mother died when she was 60, so they both died very young. So she knew and visited us in Nashville. She came to Tennessee and so on, but I was very young, just a few years into being an assistant professor. So she never actually saw me become a professor, have tenure, and go to Columbia. They both died actually very young. And that was something that's a little sad for me, I have to say.
So as you made your way through academia, particularly in the Vanderbilt years, there are a number of things that we all do that pick up, that demonstrate, if you will, our acceptance into the academic environment and the respect of our peers. What were the things that were important to you as you made your way through that period of your life, and that as you now talk to others who may do the same thing, that you feel would be important for them to do?
Clearly, election to the Association of University Anesthesiologists and my participation in that society has been very important to me. My first research abstract that I did at Vanderbilt, I remember showing Brad, and I said I was going to send it to the ASA meeting that October, and he said, well, that's fine, but you have to send it to the AUA, and he sponsored my sending that paper there. It was accepted for oral presentation, and I think that was a very important introduction to academic anesthesiology. I continued to go to the meeting on a regular basis. I served on the scientific advisory board, then the council, and I was the first woman president of the Association of University Anesthesiologists. And I think what's very important to say is that it was quite unremarked that the fact that I was a woman, and I thought that was a good thing, that it was a natural thing to happen, and everyone didn't say I was the first woman, it was just that I had been elected. So I was very proud of that. And the other thing that I really enjoyed was the collegial interchange and the opportunity to some extent to shape the specialty by being for many years on the editorial board of anesthesiology. I think that's an important position to hold. I think you see the novel and the new work that's being done in anesthesiology, and I think you have a chance there to foster it and to help young people with their first manuscripts that they send to the journal. I think that's a very important job to do.
You've obviously trained a lot of residents, fellows, and even faculty over the years. Is that something that gives you a lot of satisfaction?
Absolutely. If I had to choose one thing that I could look back on and say it's the most important thing I did, it's the relationship and the training of the residents and fellows. And for me, it's a real joy to see them do well. And I don't think you can be a chair of a department and do it successfully if you're not really, really pleased and you're not happy and joyous and celebrating your trainees' success.
Well, Margaret, thank you very much for this interview today. It's certainly been enjoyable to talk to you. Not that I don't do that every day, of course. The one thing I'd say, just to wrap it up, is that we've focused largely on your academic career and your academic achievements, but I, of all people, can attest to also how well you've done bringing up two very successful and well-adjusted young men, and as a mother and a wife. I think that's an achievement you should not underestimate, and I know you don't. So thanks again for the interview. It's been a pleasure to talk to you.
Thank you. Thank you.